Yep, good morning, dear students. This is Aminova Nigina Aminovna, and we are starting the new lecture that is the precancerous lesions of oral cavity. And before we move to the classification and etc., let's start from the popular definitions given by World Health Organization to different terms. The first one is precancerous lesions. A morphologically altered tissue in which cancer is more likely to occur than in its apparently normal counterpart. Precancerous condition is defined as a generalized state associated with a significantly increased risk of cancer. And the third term that is defined is a premalignant condition. It is a group of disorders of varying etiologies, usually tobacco, characterized by mutagen-associated, spontaneous, or hereditary alterations or mutations in the genetic material of oral epithelial cells, with or without clinical and histomorphological alterations that may lead to oral squamous cell carcinoma transformation. And let's move to the classification. Classification of premalignant lesions. Leukoplakia, proliferative verrucous leukoplakia, intraepithelial carcinoma, erythroplakia, and the palatal chains associated with reverse smoking. And this is given by SamARQAND. And this is also could be OSMF, lichen planus, Rosev type, sideropenic dysphagia. This is Plummer-Vinson syndrome, syphilis glossitis, discoid lupus erythematosus, ectoderma pigmentosum, and epidermolysis bullosa. Introduction. Premalignant, precancerous, potentially malignant oral lesions. They involve skin lining of the mouth, known as the epithelium, at risk of transforming into an oral cancer, and it is difficult to predict which lesions will transform and how long it will take. And this involvement is given by Victor Babes. Etiopathogenesis. Salivary theobarbituric acid reacting substance and advanced glycation and PDATS. Expressions of CK8 and CK18, expressions of podoplatinin and ABCG2, prevalence of P53 mutations. No significant difference still are seen. Risk factors. People of the age group of less than 40, poor oral hygiene, genetic theory still could have the effect. Habits such as tobacco, smoking, smokeless or inhaled, pan masala, betel nut quid, heavy alcohol use. Although such lesions can be found in younger individuals and those without classic risk factors. Clinical features of precancerous lesions. Lesion lasts for 14 days, requires a diagnostic biopsy even after irritant is removed. Anatomical locations are epithelial dysplasia and leukoplakia. So here are the percentages of buccal mucosa, palatal, floor of the mouth, mand mucosa, and sulcus, and also buccal mucosa. Next is, Mean age for diagnosis is from 37 to 59. In 5%, it could be met in people at the age of 30 or above. Epithelial dysplasia is mainly met in male. So dysplasia definition is that dysplasia comprises a loss in the uniformity of individual cells as well as loss in their architectural orientation. It is characteristically associated with protracted chloronic irritations or inflammation. Histomorphological changes of dysplasia: loss of basal cell polarity, parabasilar hyperplasia, increased nuclear cytoplasmic ratio, drop-shaped ridges, abnormal epithelial maturation, increased mitotic activity, mitosis in the superficial half of the surface epithelium, cellular pleomorphism, nuclear hyperchromaticity, and enlarged nuclear. The last two are loss of cellular cohesiveness and the individual cell keratinization in the spinose cell layer. So moving to the next slide, these are the histology and clinical development of the dysplasia, tumor, normal mucosa, and precancerous field. So here in the pictures, you could clearly see how these symptoms could be found and how to differentiate the actual illness, precancerous state of the human mouth. So here you can see the clinical view, so the parts of the tongue that it could be met, and also the histology, like how it is seen under the microscope. Leukoplakia. A definition given by the World Health Organization sounds like it is a white patch or plaque in the oral cavity which cannot be scraped off or stripped off easily, and moreover, which cannot be characterized clinically or pathologically as any other disease, which makes it really difficult to differentiate. It originates from Greek word leukos, white, and plakia, patch, a predominantly white lesion of the oral mucosa that cannot be characterized as any other definable lesion. This is the recent definition that is given by Schwimmer in 1877. Classification of leukoplakia based on clinical type. It could be classified as homogeneous, smooth, furrowed, and ulcerative. Non-homogeneous, ulcerative, verrucous, and also speckled. Based on etiology, tobacco-associated or idiopathic. Based on extent, leukoplakia can be classified as localized or diffuse. It can also be classified based on the risk of malignant transformation. It could have high risk or low risk sites. In high risk sites, the fields that are mostly infected are floor of mouth, lateral ventral surface of tongue, and soft palate. And in low risk sites, the sites that can be infected are dorsum of tongue and hard palate. Based on histology, leukoplakia can be characterized and classified as dysplastic or non-dysplastic. So let's see. Sharp staging of leukoplakia. Stage 1. So Sharp says that the leukoplakia could be staged in three, and the first stage is earliest one. It is non-palpable, faintly translucent, and white discoloration could be noticed. And in stage two, it is mostly localized or diffuse, slightly elevated plaque of irregular outline. It is opaque, white, and may have a fine granular texture. In the stage three, it is also already thickened white lesion showing induration and fissuring. Clinical presentation of the leukoplakia, solitary or multiple. It is also called plague, from Greek white patches. It varies from the non-palpable, faintly translucent white area to a thick, fissured papillomatous or indurated lesion. In 70% in buccal mucosa, commissural areas, followed by lower lip, floor of the mouth, palate, and gingiva. Symptoms that leukoplakia could be spot are feeling of increased thickness of mucosa, ulcerated or nodular type, burning sensation, right? Enlarged cervical lymph nodes, metastasis. So here you can say the speckled or nodular, and this one is ulcerative. Moving to histopathological features, you could see keratinization pattern, thickness of epithelium, changes in underlying connective tissue. Waldron and Schaffer also mentioned that 80% lesions show benign hyperkeratosis with or without acanthosis. This plastic change typically begin in basal, parabasal zones of epithelium. Conservative management that could be done in this case is the elimination of etiological factor, be it smoking or alcohol abuse, restraining from smoking or chewing tobacco, to remove sharp broken down teeth, and the correction and the replacement of overhanging or faulty metal restorations with a metal bridge. Chemoprevention. What could be done to prevent it with the chemical substances? Isotretinoin, beta-carotene, topical blomycin, and fluorouracil with cisplatin. Surgical excision. Entire lesion excised if it is 1 centimeter less in size. Following modalities used: scalpel, surgical stripping, cryosurgery with liquid nitrogen, electrocautery, or laser ablation. We are also going to talk about erythroplakia. The definition that is given by World Health Organization is that erythroplakia is any lesion of the oral mucosa that presents as a bright red velvety patch or plaque, which cannot be characterized clinically or pathologically as any other recognizable condition. So the definition, I would say, is quite similar to leukoplakia, but still there is a difference. Classification. It could be classified as homogeneous erythroplakia in terms of clinical variants. It can be erythroplakia interspersed with patches of leukoplakia. So here you see they kind of get together, and granular or speckled erythroplakia. Speckled actually was the type of leukoplakia that we could also see in people. Next, it also can be smooth and granular, nodular, well-defined, may have an irregular red granular surface interspersed with white or yellow foci, soft on palpation. So And the management that we can do is biopsy, treatment guided by histopathological diagnosis, recurrence, multifocality common, and careful long-term follow-up. So we really need to take care and to observe this case in patients. Intraepithelial carcinoma, it is also called carcinoma in situ. Most severe stage of epithelial dysplasia. So its striking features or dysplastic epithelial cells do not invade into connective tissue, common among elderly with a male predilection, present as white plugs or ulcerated, reddened areas. The sites that are mostly infected are floor of the mouth, tongue, and lips. It has combined features of leco and erythroplakia. So this is something they can combine. And the treatments that should be made is no accepted treatment. So actually you don't have anything to do about it. The only thing could be surgical excision, irradiation, or cauterization. Oral lichen planus, named by Wilson. It's a British physician that discovered it in 1869. Lichen is a Latin for primitive plants, symbiotic algae and fungi. And planus is a Latin word for flat. So it is literally flat primitive plants. Definition is that oral lichen planus is a common chronic immunologic inflammatory mucocutaneous disorder that varies in appearance from keratotic to erythematous and ulcerative, affecting the stratified squamous epithelium. Etiology and pathogenesis. Both antigen specific or non-specific mechanisms can be involved in pathogenesis of OLP, oral lichen planus. Antigen specific mechanisms, antigen presentation by basal keratinocytes and the antigen specific sorry for mispronunciation, keratinocyte killing by CD8 plus cytotoxic T cells. Non-specific mechanisms, mast cell degranulation and matrix metalloproteinase MMP activation. These mechanisms may combine to cause T cell accumulation in superficial amenapropria, basement membrane disruption, intraepithelial T cell migration, and the last one is keratinocyte apoptosis. Clinical features of OLP is that lesions usually symmetrical, frequently affects buccal mucosa, tongue, lip, and palate. Extraoral mucosal involvements, anogenital area, conjunctiva, and larynx. Approximately 1 and 2 and 5 and 3% lesions undergo malignant changes. Therefore, regular follow-up mandatory. It could also be seen on skin, flat-topped purple polygonal and pruritic papular rash. In oral cavity, it is asymptomatic, reticular or plug-like. In reticular, it is Wickham's stripe, plus minus discrete erythematous border. In plug-like, it resembles leukoplakia, common in smokers and tobacco consumers. Clinical features: symptomatic, it could be atrophic, erosive, and bullous. In atrophic, diffuse red patch, peripheral radiating white stray. In erosive, you can see irregular erosion covered with a pseudomembrane. And in bullous, small bully vessels that may rupture easily. From the point of histology, 3 classic microscopic features of OLP could be seen. overlying hyperkeratinization, a band-like layer of chronic inflammatory cells within underlying connective tissue. And you can also see liquefaction, degeneration of basal cell zone. So 3 type of layers. Diagnosis. You can do oral biopsy, direct immunofluorescence. The management, how we can deal with this situation. Reticular type is asymptomatic and the treatment often unnecessary. Erosive type presents significant management problems. All patients should optimize oral hygiene. Oral candidiasis should be excluded or treated. Corticosteroids in the treatment of choice, for example, fluocinolone or clobetasol gel for 2 weeks with 3 months follow-up. In symptomatic patients with apparent contact dental factor, patch test with replacement of amalgam. In those with no apparent contact factor, topical or intralesional steroid, first-line treatment. A short course of systemic steroid for more rapid control. So let us finish here, and this is the slides on oral submucous fibrosis. So this part is left for you to learn independently, and the most of the clinical and diagnosis and histological features of the precancerous lesions are given already, so you can actually use them and let your lecturer know about the questions that you know and want to ask the answer for. So here we are going to conclude our presentation. Patient presenting with potentially malignant disorders should undergo a careful examination to identify any causative factors, which are best eliminated at the first stage of the treatment. However, many patients may not have any obvious causative factor, like it can be hereditary or it can be, not symptomatic. A biopsy of the lesion is necessary to demonstrate the histological features of the lesion and detect any existing invasive carcinoma. Frequent monitoring of histopathological changes is essential to obtain an accurate assessment of histological activity of the lesion and to try to predict its future behavior and how it develops. The subsequent management of the patient depends on how high risk the lesion is. So, wish you a good day and luck with your studies. See you in the next lectures.